All right, let's get ready, and we're going to talk about mixed medical muses. You say, what is a medical muse? Back in the day, the ancients, they would translate things to their understudies through stories, through discussions, even around the fire, the campfires. They would translate and give information. Nowadays, we have the internet, and we have all these resources that we can use and pull. What we're doing is I'm telling you stories that may have been good or bad, that you can learn from and be able to take care of patients, number one. Number two, pass your boards and do well and excel in life and be super cool. So let's get started and let's get going with the mixed medical muses.
Stand clear of the closing doors, please.
When we're learning, I want you to think about this, and this is something I wish they taught us in school, is the steps of learning. And these stair steps, in order to get to the top part being knowledge, and having this knowledge to be able, in our cases, to take care of patients. Now, if we take too big of a step, it becomes impossible for us to understand. We can't break down this information, and we have this huge step. If the step is too little, is we lose interest. So we're trying to get you in the proper steps, in on these stairs of knowledge and these stairs of learning. Sometimes if you feel we're getting a little bit too low, like it's too little of a step, we're trying to pick this up so you get this learning where it's the perfect step for you. And when you're watching these, you may need to speed up the films or slow them down so that you get to the right steps of knowledge. And I want you to think about that. If you cannot attain a topic, is the steps of knowledge too steep or too little? And we also have in our board review series, we have very detailed sections that you can go specifically to those and to work and get those steps of knowledge. We also have multiple choice questions that you can get to, and we also have flashcards that will help you build those steps of knowledge. And some days you have to kind of work through and hit the problem from multiple different angles. And you're going to see sometimes we're going to give examples from multiple different angles so that you can attain mastery is what our whole goal is. Now, the goal of this is to push your emotions. If you have an emotional response when I'm giving you knowledge, you'll remember it better. Just think about times that you remember in your life, either they're good or bad, there was an emotion connected to that, and it makes it much easier to pull out of your hard drive up in that head of yours. And we want to pull where you can pull this information out in your hard drive so you can answer board questions and you can take care of patients and look cool. The whole goal is to put it in your hard drive so that you can pull this material out quickly, rapidly, and correctly. All right, let's give an example. And this is a tribute patient. And you say, what is a tribute patient? This is a patient where we change some of the information up, but this is a real person. And we need to talk about real people because we learn about patients, taking care of patients from either mistakes or things that occur to us while we're working on patients. Just remember, the famous words of Bon Jovi is the song remains the same, only the names has changed. Now, sometimes you may hear when we're doing a tribute patient, we're having a discussion, you may hear my voice crack. Because I'm thinking about this patient when I'm talking to you. And sometimes these patients don't do well, and it brings up emotions. And that's an okay thing. We have multiple choice questions and real world scenarios that will lead you to a better clinical practice for you so that you have multiple ways of learning on how to take care of patients and to work up complex patients. Remember, in the real world, I've never had a patient come to me with a multiple choice question. I wish they did. It'd be a lot easier, and I could just put it in ChatGPT or OpenAI, and I could get in there and I could get the answer. Unfortunately, they don't come with the multiple choice questions. Now, boards test you on multiple choice questions because it's very hard to do didactic training and didactic testing on a massive scale. So that's why we do multiple choice questions. It's what we have available. But let's talk about the reality of a patient. Okay, let's get his patient. This is a 72-year-old male. He comes in after he's a farmer. And the interesting thing about him is that he advertises, or his family advertises, he's never been to any type of provider. He was born by a midwife out on a farm. He's never had any blood tests. He's never had any imaging, and he's never seen any type of licensed provider before. He was born by the midwife. He was found by his family laying by the side of his tractor. And he was laying there, and he'd had these events where he's doing well, he's answering questions, and all of a sudden he's kind of going like this, going like this, going like this, and kind of shaking both sides, and then kind of collapse, then would wake up and answer questions. Now, he doesn't remember those time periods where he's going like this and collapsing, and what is he doing? I don't know. Is he seizing? So he's able to remember some things, but not when those events. So is he seizing? But he comes out of it. So what's an important thing that would say, maybe this isn't a seizure? Is guess what? He has no postictal state. He pops right out of it. So less likely to be a seizure. Now, once you get him in, they look at his monitor, and he's noted for these weird arrhythmias, where his heart rate is popping up to the 170s at times when he's having these neural events. It goes up to 170s, and then it stops and goes away. It's noted for that. So also, too, is that he's noted when he do labs, they finally get all these labs done, he's noted for potassium 7.4. 7.4, a hemoglobin of 5.7 with a creatinine greater than 20. And you're going to say, what is this presentation? And he said, why do you have this picture of here of what is this? And this is CT imaging. And so, first of all, he comes in, we get him stabilized. And the first thing, our biggest thing, remember, you always want to take care of the thing that's going to kill the patient the first, is this horrible arrhythmia that he's having, that we're noticing these neural events on. We feel that the arrhythmia is triggering these neural events. Now, do we still need to work for a seizure? Oh, yes, we do. But we need to first stop these arrhythmias, because these are becoming very scary, very fatal. And what do we need to do? Is we need to get that potassium fixed first. So first thing is emergently put a hemodialysis catheter in, and we take out this patient's blood. And in the CRRT, we'll talk about CRTs, what we're doing is we're pulling the potassium out of his body, okay? So we get his potassium normalized, we give him blood product too, okay? So after stabilization, we get imaging. We get imaging, and on this imaging, let's get this right here. I'm gonna draw on this real quick. Is on this imaging right here, we have this right here. We have this big bladder. See this big bladder right here? And then we'll look right here. So this bladder, and talking to the urologist, is estimating holding 3 liters. Now, I've never seen a 3-liter bladder. I always thought that if you went over a liter, in my mind, is that bladder is gonna burst. Well, he proved me wrong. So this, according to talking to the urologist, is that he had this happen chronically over a long period of time. Remember, this patient is not a complainer. He doesn't go to providers, doesn't go to doctors, doesn't have any labs. So what is causing this? So remember, when we pee, we have urine is formed from the kidneys down to the ureters, down to the urethra, right? But he has something called a prostate because he's a male. And his prostate was enlarged. And what happened is, if you asked him when we got him normal, we got the potassium under his prostate, he was saying that I had trouble starting and stopping my pee. And sometimes it took me forever just to pee. And it just got worse and worse over time. So his prostate became enlarged and he had trouble peeing. So what happened? Everything backed up. Everything backed up to his kidneys, and he wasn't able to pee out potassium. So he's eating food with potassium. He's not able to excrete it because everything's backed up, and he's not. So what happened is they were able to place a Folian. He was able to pee, plus the CRT were able to normalize his labs. Once we were able to get his potassium under normal levels, is that we were able to get him imaging for him. He was stabilized. Now, we also were able to see is once we put the Folian, and you can see on imaging, see the stuff right here? There's some stuff in there, and some of it could be a mass and some of it's blood product. So this coming from the prostate. And then we took the prostate and we had a PSA of 88. So we checked the PSA is 88. So he likely has malignancy. Now he refused to have a biopsy done by the urologist. They put the Folian, and they're gonna work on another possible treatment for him, maybe a suprapubic catheter, if he'll allow that. He doesn't really want treatment. So this is how prostate cancer, likely prostate cancer, because he never had a biopsy, you have to have a tissue to get the biopsy, is that likely this patient had prostate cancer, and this prostate cancer caused him to have a hyperkalemia. From this hyperkalemia, he had a neural rhythm where he had seizure-like activity from what? From the cardiac arrhythmia from this hyperkalemia. Isn't that kind of crazy? So hyperkalemia leading to seizure-like activity. So you have a patient looking like they have seizures, but it really is suspected prostate cancer. So we're going to give you bits of information like this that will give you bites of knowledge to, yes, answer your board questions. I know you want to pass your boards and do well, and we're going to help you do that. But we're going to give you different style lectures, and we're going to give you different types of questions, so that way you can kind of see different ways of obtaining information, putting it on a hard drive, being cool, answering questions, and taking care of your patients. Here's another one. This is a 54-year-old female with past medical history of diabetes. So presents with nausea, vomiting, fatigue, and some confusion. Now, on physical exam, she also has asthma too, taking albuterol, never had a PFT. So remember, on asthma, we have to know, get the echo of the lungs as getting a PFT. She never had a PFT, she has asthma. So she presents with Kussmaul's breathing. So Kussmaul's breathing, what is it? Deep, fast breathing, deep, fast breathing, deep, fast breathing, okay? So what she's trying to do is correct an acidosis, okay? So she's noted for on labs is an anion gap greater than 36, a glucose of 23, that's a really low glucose, that's dangerous. And a creatinine, let me get this different color on here, I wanna look pretty. A creatinine of 9.8, and a bicarbonate less than 5, and a pH of 6.74, lactic acid of 22, and a white blood count of 26. So what else? So let's talk about and let's think about this patient. So they have is their diabetes. What's the #1 drug for diabetes? What's first line? First line currently, metformin. Metformin, correct. Metformin. Now, this patient has a lactic acidosis, and they're taking metformin. Now, there was this famous meta-analysis done by a famous group, we won't mention the name, that showed that there's no concordance of lactic acidosis. Well, that's probably wrong in individual cases. They're saying grossly, is there a chance of lactic acidosis? Probably not in most of the population. In this person, probably is, where they're having lactic acidosis, likely second to the metformin. The albuterol isn't likely to cause this. So on physical exam, we talked about they had Kussmaul's breathing, and then they had what's called livedo reticularis, okay, which is a bluish gnat-like rash, which is going to show altered, and we'll show you a picture of this, altered blood flow in the surface vasculature. It's not sensitive for vasculitis. It can be in connective tissue disorders. It can be just poor blood flow. Here it is right here. Here's an example. So livedo reticularis comes from the Latin word liveri, which means bluish, reticularis, gnat-like. So blue gnat-like, you got to agree that's what it looks like. Now, this can be caused as something as simple as cold exposure that resolves with warming. It can be from lupus, rheumatoid arthritis, connective tissue disorder, antiphospholipid syndrome, thrombophilia, hepatitis C. It can also be medications. If there happen to be on interferon, amantadine can cause these. Other conditions can see this as pancreatitis, hypothyroidism. So we know this isn't a good thing. It could be as simple as just somebody is more sensitive to cold exposure than other people, but it could be also mean as they may have an underlying condition. So remember, you gotta go and look at your patient. You can't fly a drone into the room and just peek at them. You gotta actually touch their skin. You have to look at their surface. You gotta lift that thing called the blanket. You have to lift it up so that they can see the patient, unless you have x-ray vision. So here's another picture of it. Here we go. So impaired blood flow to the small vessels under the skin surface. This is reduced blood flow leads to decreased oxygen delivery, causing affected areas to appear bluish or red-purple right here. You have to agree that you can see this. Now, this is another thing. Now, this isn't exactly this patient, is they had a rash. Now, we're gonna talk about different types of rashes, and we'll have a whole lecture on rashes, okay? But let's talk about this. See this? This is a malar rash. Now, this isn't perfect on this one, but see there's some redness here, there shouldn't be that. So it's not a perfect malar rash, but malar rash, nasal labial sparing. Okay, now what these nasal labial fold sparing? Now, what diseases can do this? It can just naturally occur with some people, but associated with lupus. Now, and other connective tissue disorders, but it can be associated with lupus, and about 50% of lupus can get this butterfly rash, where you're not gonna get any discoloration here in the nasal labial fold. Now, what happens now in this patient? So they came in. they ended up testing positive for lupus. So what happened is they had lupus, it hit their kidneys, they were taking the metformin like they're supposed to, and what happened is it built up and had this lactic acidosis. The metformin, the action of metformin was working, so that lowered their blood glucose. Now they also had a pneumonia too, because they were so out of it that they aspirated and had an aspiration pneumonia. So lupus is what? Now, what if this patient, instead of having a malar rash, had where this was colored here? And you see my beautiful drawings right here where I'm coloring this in, and we have complete redness right here. What is this? This is called erysipelas, where we have erythema all the way through in the face. It's not sparing the nasal flavor. We have redness all the way through. And what can cause this? Group A strep can cause this. And so those are things that you can look at. And that's why we have to learn how to do a physical exam on patients and actually do the physical exam. We have to be able to touch our patients and actually lift up those things called bandages and blankets. I know they're heavy, but you have to lift them up, okay? Now, what can also cause this patient to be confused? They have lupus, and what can cause confusion? Lupus nephritis, cerebral lupus. So these are things to think about. That's why you have to understand these diseases. And we're going to talk about these important diseases. Lupus is an important disease, and it can affect people, and it can affect their whole body. So let's kick it. Let's get started. We're going to have modified real-world experiences, okay? And what we're doing is the patients and families wanted these events to be told in a training environment to prevent future harm. Now, there's errors been made on patients, and we'll discuss those, but we have to acknowledge that we have failure helps the future. We learn from failure. Don't believe it? Look at Alexander Fleming. Alexander Fleming, the father of penicillins, the father of antimicrobials, we'll call that. He made a mistake. He basically did a poor culture, and people said he was sloppy. And he was sloppy in what he did, and he made a mistake, and this is where we got penicillin from. So life and death happens. Life and death happens. And we're going to learn this. And I want you to get in a habit of everybody you're touching, I don't care if it's inpatient or outpatient, is to discuss goals of care. You want to know that the goals of care of these patients. You do not want to take away their rights for them when they have no ability to fight and to be able to take care of themselves. You want to know what they want. And that's consistent across the board ethically, is that we take care of the patients the way they want to be taken care of. If they want to be focal, if they want to be DNR, it's not what we want, it's what they would want. And having discussions with them and having open discussions with their significant others so that it's known. Remember, first do no harm. I guarantee you that none of you, when you signed your personal statement, said, I want to harm people. I guarantee you that you didn't say, I want to harm people on your personal statement where you said, I want you to be harmed. No, you're here to take care of patients. So first do no harm. And that's what we're going to discuss, is first do no harm. And then I really like this, is it says you matter and then I matter, because we have to say is I matter as a provider and that we are people as providers too. All right, so now I'm going to talk about things that may make you annoyed, okay? So let's talk about RALs on physical exam. They went bye-bye. You say RALs went bye-bye, you're like, that makes no sense. They went away in 1977. You say, well, that doesn't make sense. If I go to the big high-cost EMRs, I can click on a box under physical exam to say RALs. Well, they went away. I can tell you that RALs came about as a term. Ray Laennec, he's the guy that invented the stethoscope. In 1816, he invented the stethoscope, right? Because he got tired of putting his chest up against women's boobs, okay? So he's tired of putting his ear up to women's boobs, and he invented the stethoscope in 1816. This is a mistranslation, he was French, where RALs came from. But we carried it on. That's one of the things we need to think about in medicine is we carry on mistakes, and we need to learn how to break those mistakes, and we need to move forward. Now, this was standardized by the American Thoracic Society back in 1977 in American College of Chest Physicians. And this was standardized by them and noted that this is not the correct terminology and that crackles are fine, okay? So instead of RALs, you need to use the term crackles, coarse or fine. And we'll discuss this in our pulmonology section, it's coarse or fine. That is the correct terminology. RALs went away, and I know it's there, but this is a discussion how we're going to break some of these things and discuss what the actual things we need to be taking care of our patients. Is it a big deal we call it RALs? Not really, RALs, but crackles are correct. Now here's another one that's going to blow your mind. This is back in 1997, and this is busting dogma. I guarantee you can go to the high-priced EMRs right now, and you can click on there where it says sclerectosis. Well, guess what? Back in 1997 in JAMA, this is a Journal of American Medical Association. So this is to the medicine doctors. This is by one of the opto. The eye docs goes, listen, there's no such thing as sclera ictus. The sclera can't be colored. It's conjunctival ictus. Look at the sentence they wrote, and he says, hey, this is a mic drop. You can't have it. There is no such thing as sclera ictus. Now, I know you go to the high-priced EMR, and you click on the physical exam under eyes, and it says sclera ictus, this is your choice. It's wrong. It's wrong. So we need to realize is that things that we be taught and are handed down, they're wrong, and we need to bust this dogma. I guarantee you 50% of what I say or what any of the best expert anybody says will be wrong, in about a couple years. Just give it time, and we're moving faster and faster. Where things like beta blockers that sat on the shelf for 30 years because no one wants to slow the heart down when someone's having a heart attack, right? That's stupid, that's crazy. But guess what? What are we using now? So we're using beta blockers. It was found by accident. Penicillin formed by accident. So these are things that we need to bust dogma, we need to change. I know that you're a hospital, you have all the greatest stuff, that you have lasers from your fingertips and you can cure cancer, but the boards isn't designed for that. It's designed for center mass, where most of the hospitals in the U.S. system are sitting, most of the clinics in the U.S. system are sitting. You're gonna have all these great things that you may have access to that other people don't. Also, I want you to think about this. I like this, is patients in isolation may not take their toys into the rooms. Is the Dunning-Kruger effect. Is where people with the least amount of competence and overestimate their abilities. So people with the least amount of competence in what they're doing are overestimating their abilities and creating dogma that we follow. I want you to break that and think about it.